Welcome back, future doctors. Today's topic is acute bacterial meningitis, a true medical emergency every clinician must recognize. Let's begin with the history. Risk factors include exposure to meningococcal meningitis, travel to the meningitis belt of sub-Saharan Africa, extremes of age, immunosuppression, and recent head trauma. But remember, most cases are sporadic. Now the clinical presentation. It often starts like a flu or upper respiratory tract infection, then rapidly progresses to fever, headache, vomiting, photophobia, lethargy, rigors, seizures, and neck stiffness. Seizures occur in 20 to 30% of patients. With Neisseria meningitidis, half of patients develop a classic rash that evolves from macular and erythematous to petechial or purpuric. Cranial nerve palsies, especially 3, 6, 7, and 8, occur in about 10 to 20%. And in the elderly, symptoms can be subtle, sometimes just confusion or lethargy without fever. Moving to diagnostics, blood tests usually show elevated WBCs. Blood cultures are often positive. The key is lumbar puncture with findings of opening pressure above 180 mm H2O, turbid CSF, WBC count over 1,000 per millimeter cubic, predominantly neutrophils, protein above 100 milligrams per deciliter, glucose under 40 milligrams per deciliter, CSF to blood glucose ratio below 0.4. Grand stain is positive in up to 90% and culture in up to 85%. Common organisms are Streptococcus pneumoniae, Neisseria meningitidis, Listeria, Haemophilus influenzae, E. coli, and Group B strep. If there are signs of raised ICP or coma, always do a CT before LP, but never delay antibiotics. Differentials include aseptic meningitis, encephalitis, brain abscess, migraines, rickettsial infections, and drug reactions. Now, the management, and this is exam gold. It's a medical emergency. Antibiotics must be started immediately. Do a quick neuro exam, draw blood cultures, and if LP is safe, perform it urgently. Empiric IV therapy, ages 18 to 50, ceftriaxone or cefotaxime plus minus vancomycin. Over 50 or immunocompromised, ampicillin plus ceftriaxone cefotaxime plus vancomycin. Skull fracture, ceftriaxone plus vancomycin. Neurosurgery or CSF shunt, vancomycin plus ceftazidime. Once culture results are back, narrow the therapy. And don't forget dexamethasone, given before or with antibiotics, especially in children and adults with raised ICP. Follow-up includes looking for associated infections like sinusitis or otitis, and repeating LP if response is poor. Close contacts of meningococcal cases need chemoprophylaxis. Finally, the complications and prognosis. Patients can develop seizures, coma, hearing loss, cranial nerve palsies, hydrocephalus, or SIADH. Mortality depends on the bug. N. meningitidis, 3 to 13%. S. pneumoniae, 19 to 26%. Listeria, 15 to 29%. Overall, 5 to 25% fatality, showing why early recognition and treatment are life-saving. T exam pearls. The classic triad is fever, neck stiffness, and altered mental status. Lumbar puncture is diagnostic, and empiric antibiotics must be started immediately.